Hello, everyone. Nice to see you again to a new edition of Beyond the Cancer Diagnosis interview series. Today, it is my pleasure to invite Gabrielle. She's Associated Professor at the University of Ghent, and we'll have very interesting discussions about colorectal cancer from both medical and psycho-oncological perspective. Gabrielle, thank you very much for joining me today.
Thank you, Adrian, for the kind invitation and for OncoDaily for organizing these interview series. It's a pleasure to be here.
We had previously a patient with colorectal cancer, and we discussed more about the impact on social life of colorectal cancer. With you, I would like to go a little bit deep of what exactly means from medical perspective this kind of cancer, and what are the steps for colorectal cancer patients before and after the surgery, because we are also surgeons, so it will be great if you can share with us all these procedures.
Thank you, Adrian. That's an excellent question. So colorectal cancer is the fourth most common cancer type, a cancer diagnosis. And over 1 million people a year actually receive this cancer diagnosis. It is an upcoming disease in the second and third world as well. And there's an increase in diagnosis in patients under the age of 50, which makes it more and more common that we have to think about fertility processes in the treatment of colorectal cancer. So normally, if a patient has colon cancer, which is the large intestine, a patient has surgery, because surgery is the mainstay, and sometimes they will have chemotherapy after the surgery. For instance, if the cancer has invaded in the lymph nodes. Unless the cancer is very advanced, and sometimes patients with colon cancer may require chemotherapy up front. So patients can develop amenorrhea during the treatment with chemotherapy, for instance. And if we think about rectal cancer, of course, the mainstay of treatment is still surgery, but we've moved towards a treatment plan incorporating more chemotherapy and radiotherapy before the actual surgery. And this means that these patients not only get a cancer diagnosis, but immediately they are confronted with the need for neoadjuvant treatment and with all the side effects that belong to chemotherapy and radiotherapy. And if you irradiate an ovary, it becomes sterile. So immediately you induce menopause in women. But you could also induce infertility in men by, for instance, giving chemotherapy or radiotherapy. And this, of course, has a huge impact also on sexual function. And with the surgery, especially in rectal cancer surgery, patients often have a temporary or permanent stoma. So this stoma also distorts the body image of patients and has an impact on relationships. Together with the cancer diagnosis, the cancer treatment, being a patient, having this sort of Damocles above your head of needing surgery and requiring a stoma, this weighs very heavily on patients and their partners.
You mentioned the issue of fertility, but also you mentioned the average year of 50. There are cases when EA, or especially adolescents and young adults until the age of 30, are diagnosed with this type of cancer. And fertility, it is an issue that, let's say, they are not prepared also for a long-term perspective in types of family or children. And when we are talking with them about fertility, they don't know, they don't even think about. So from your experience, what is the barriers or let's say social barriers, cultural backgrounds, because it seems that nowadays it is, let's say, harder and harder to make a family, to have children, and because society is developing tremendous, and we have as persons to keep also in touch with this society. So fertility remains one of underrated topics. So what is your perspective? What are the barriers of this issue?
Well, I think age is very important because there's a lot of things that we consider normal for a certain age in a person's life. So, for instance, of a young person, we expect a person to be energetic, right? We expect a young person to be outgoing, social, hanging out, not being at home, and being vibrant and engaging with people in your age, and that also includes sexual relationships, right? So, and then you have young people who are actually in a relationship, in a steady relationship with someone that may become their life partner, who they may or may not see as a future, father or mother of their children. There may be people who are, casually dating and don't have anyone in sight. And among those, you might have people who are very cognizant of their desire to have children at some point. And then there are a lot of people who say, like, I never want to have any children, or I have no idea whether I want to have any children in the future, and it might change that perspective. So this desire for children is important, but with the families surrounding these patients, there's a lot of different types of feelings. So first of all, there's you're a young person, you have cancer, this should not be happening. We have to fight the cancer and you will cure and stay alive. And that's the most important thing, which makes the fertility and all the other side effects of the treatment really second or third level of importance, right? And it's all about the fight against cancer. So once they've had this fight, and maybe they've become cancer-free, like some people will still require, for instance, hormonal therapy for other types of cancer, maybe for even after 10 years, for instance, in breast cancer. But a lot of people in the environment think, well, the cancer is gone, so everything's back to normal. But actually, things are not back to normal because they will never be the same person that they were before the cancer diagnosis and before the treatment. And then, so of course, these, especially these young patients, they need to be counseled before they actually start the treatment, which can jeopardize their fertility. So it needs to be embedded in the healthcare system that there is someone who is actually actively engaging with these patients to have these conversations in time. Because once it's too late, it's too late. And if this conversation is not handled appropriately, and the patient after the treatment discovers that they actually have become infertile, a lot of the qualitative research explains that these people feel like, wow, I now have a side effect of treatment, which was not my choice. I did not choose to become infertile. Sometimes they're not even sure whether they're infertile or not. And that is then combined with the feeling of sadness, of loss, but also frustration and a feeling of not being in control anymore. So that's difficult, and especially if the patients actually come into early menopause. All the experience that these people have of even weight gain or thinning hair or having pain in your joints or vasomotor symptoms, they're not considered age appropriate. So their environment, their friends, their families, they cannot really fit the symptoms that they have and the impact that this has on their daily lives with their age. So there's a type of ageism which can make people feel very isolated. And they also have to deal with the long-term effects of menopause, for instance, a high risk of osteoporosis or hypertension. And they're often not counseled well enough, for instance, in having hormonal substitution therapy. And that's also sometimes a bit of genderism, but also a bit of ageism, where people will be like, even healthcare practitioners, well, you beat the cancer, you're cancer-free. Why do you worry about fertility or loss of libido? Because that is not, the most important thing is that you're alive. So this is a very difficult situation for these young people.
But I have to ask this: did you had cases when, for example, there were a female pregnant diagnosed with colorectal cancer?
For now, I've had patients who wanted to become pregnant after the treatment for colorectal cancer with infertility, but have not experienced pregnancy during the diagnosis yet. And I'm hoping I won't come across these cases. Although it has become more and more accepted for cancer patients to undergo chemotherapy treatment during pregnancy, with very limited or no impact on the fetus. But of course, radiotherapy is more difficult. I did come across one patient with cervical cancer who had very advanced case of cervical cancer, who was actually pregnant. And this patient was counseled to break off the pregnancy and undergo radio and chemotherapy. She already had quite a bad prognosis, and she decided to refuse treatment and actually deliver her baby, which was healthy, but she died within 1 year of giving birth to that baby.
This was my next questions, because this is also a myth about chemotherapy and pregnant women. So what is happening, how dangerous it is, and what are the recommendations from the medical staff, because as we all know, the medical staff decide, but as you mentioned, it comes that call shared decision making. So it depends from hospital to hospital, from medical team to medical team, how much they imply the patients in all these decisions making treatments, which we all know that they are not easy to take, especially when in cases like this. And in general, these discussions about fertility, it is during the treatment, before the treatment, what are because we are talking now about creating or starting a family, but the statistics mentions only the, let's say, intention. Sometimes in my life, if I'm an adolescent or young adult, I would like to. So from I would like to really happening, it is a long way. So when it's the most appropriate point to start discussing about fertility issues, when the first time patients come, or you see how the treatment evolves, and then you interfere this nuance, which is very, very sensible for the future.
Well, yeah, sure. So, of course, you need to be sure that the patient is still in the reproductive age to make this, discussion apply. If it's a very early cancer, which for instance can be treated endoscopically by a gastroenterologist, for instance, or by surgery, then you may never have to discuss the fertility issues. But if it's a later stage or advanced stage or a rectal cancer stage that requires chemotherapy or radiotherapy, you have to start the discussion before starting the chemotherapy or before starting the radiotherapy. And the options would be, for instance, for men to have their sperm frozen. And it's interesting because some of the research on early onset rectal cancer show that even with men with, for whom actually freezing in sperm is relatively easy, it is often not offered consequently in healthcare systems. So this really needs to be part of like any discussion with these young men as well. And for the women, you could freeze their egg cells, as long as they don't have any tumor on their ovaries, for instance. And sometimes you can freeze in ovarian tissue, or you could even freeze in an embryo if you go a little bit further. And that does solve like some issues for young people because they feel like, well, I have a plan B. But even then, although there is a plan B with frozen tissue, it is still a question whether eventually this will result in a healthy pregnancy and a healthy child being born. Because you would still be relying on artificial procedures, like, for instance, IVF or ICSI, to actually conceive a child. And sometimes, just the idea of having this being done artificially, instead of being able to like conceive a child during a natural process of sex, for some people, this can be a barrier still. And also like during lifetime, things can change. Also, if there's like a genetic syndrome underlying the disease that you had as a patient, you could be afraid of passing that on to your child. And that could also hamper, your idea of what do I want to do. And we must not forget as well that women, like female patients, are 6 times more likely than men to be left by their partner during cancer treatments or for severe illness. So even though, their partner may be part of these conversations in the beginning, it does not mean that eventually even the couple will stay together. And also this fear of being abandoned can be quite omnipresent for patients and be a constant fear. And you also see that a lot in breast cancer patients, for instance, that because their breast looks different, they're afraid that their partner might leave them for a woman with normal breasts, for instance. And this, it's not just the fertility, but it's also about being able to provide your partner with the future that he desired, for instance, to be a father. And there can be feelings of guilt if you're no longer able to provide your partner with a child. And on the other hand, if your partner has no desire for children, but you as a female patient do have a desire for children, you can feel very alone in your wish and feel unsupported by your partner. And that's just also where the communication skills and needs can differ between men and women. We see from qualitative research that the female patients have more needs to share their feelings and to communicate, not only about their sexuality and their needs, but also about these feelings of guilt or inadequacy or loss. Whereas some of the men, may respond. There are partners, of course, that communicate very well, but you often see, this dynamic of the men just pretending that it doesn't exist and not engaging in this conversation or not joining their partner to a consultation with a sexologist or with a menopause consultant because they're like, well, this is kind of your thing. Like, what can I bring to the table? Whereas the women would, like to have this active support and feel listened to and being engaged and maybe even being validated by their partner for having these feelings.
Uh, we all know that after a cancer diagnosis, fear comes as a natural emotion. Like it's the only negative emotions out of them. But after, the patients should learn, as you mentioned, to apply coping mechanisms, strategies mechanism, and for the first, let's say, 24 hours, they are very emotional. These decisions that you talk about and we talk about during this interview, they are taking rational or emotional, because it seems that the emotional part is very, very high during these conversations within couples, within families, between patients and doctor. And I want to ask you, it is a rationality? Does the patients have a rationality, or are they are rational in taking these future decisions?
Well, we know that about half of the patients who are offered this possibility of fertility preservations, actually accepts it and undergoes this. And I think, as in many situations of getting bad news, that the emotions are, quite extreme. But it really depends on the people who are supporting this person, what they can bring to the table and how rationally they approach this. And I would say that it can be a very rational decision to also not do fertility preservation if you don't have an active desire for more children, if you never felt this was your responsibility or desire to carry this responsibility in the future. And of course, there's a set timeline as well. So there's a lot of pressure for needing to decide as well. And I think, for instance, having a general practitioner or a psychologist or fertility preservation specialist talk about this with patients is very important. But if we look at the perspective from the patients, there's a great role here for nurses. I think nurses are far more focused on trying to guide these patients through these decisions than doctors are. So the doctors are more like, including myself, these are the options, these are the pros, these are the cons. You need to make your decision eventually, and I can help you with arguments to go towards one decision or the other. But to really cope with these emotion shifts and also bringing in a portion of rationality, that can really help. And I think it also, the nurses are a great resource of patient experiences. So they can, for instance, mirror that experience and say like, well, you may think like this now, but I also had a couple, who had one child, but, and they thought it was enough, but eventually they were really happy that they were able to conceive a second child, eventually. And I think the cancer diagnosis really shakes at your basis of your existence. And really, in those types of periods, you live from hour to hour or from day to day. And it's really difficult to foresee a future where you're actually a cancer survivor and how you'll feel in 5 or 10 years' time, especially if you're a young adult with cancer. Once you're in this small cocoon of hour by hour. So having the support and having the professionals going and offering, having these conversations with people in depth and following up on that is really important.
We all know that in cancer patients' life, the family is the first line of defense, and in hospitals, as you mentioned, the nurses are playing a crucial role because they are all the time with the patients. So they know all their needs, and as you said, that can direct the patients or giving example or just being there for them, what is called that human touch, which is very, very important during the whole process. So as for the last questions, because we are finishing our interview, how you see the future of this issue of, let's say, not fertility, but in the next decade, this type of colorectal cancer, the developments that are within?
Well, first of all, we can see that due to screening programs, we catch colorectal cancer patients at an earlier stage, which is good, and which also means that people can undergo far more simple procedures instead of surgery and escape chemotherapy and radiotherapy. We also see that, especially the total neoadjuvant treatment with chemo and radiotherapy before surgery, results in patients who have a complete clinical response. And this response, is not always lasting. So we will see more people who will be followed up very closely, who develop high anxiety for each investigation, and who may or may not require surgery after all. What I'm hoping for is that there'll be less stigma, that also healthcare professionals will seek actively to be educated on counseling patients on sexual health during these cancer treatments. Because we see from our research that those who've had education, they feel more comfortable talking about sexuality with patients. And they also have less assumptions, like, for instance, this is not a good time to talk about to patients about this, or this patient will not accept me talking about this. And there's more awareness among healthcare practitioners, including doctors, that patients, like over 72 or other research, 80% of the patients expects the healthcare practitioners to initiate the conversation about sexual health. And I think this is very powerful. And once this is sunk in, I think we can take more responsibility, also as medical doctors, to have these conversations. And also personally, I'm working on a project, for instance, on vaginal reconstruction on patients who had pelvic exenteration surgery, with all the organs being basically removed from the pelvis with huge impact on sexuality. So we're hoping in the next couple of years to also provide more qualitative and quantitative data from patients, partners, and healthcare practitioners, so we can counsel these patients better and have hopefully better outcomes.
Okay, you mentioned about stigma and especially about self-stigma, which is also another subject that requires maybe another interview, because the majority of cancer patients are doing this so-called self-stigma, thinking, why me, what is happening with me, so how my life would look like. But for today, thank you very much, Gabrielle, for this interesting discussions. Very, very, let's say, innovative in terms of approaching this type of cancer. Thank you, and good luck.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.